A very good morning to you. Thank you so much for keeping it Y254. We trust that you enjoyed your weekend. It definitely has been quite an exciting one. Of course, with the Portugal and Spain match. Oh, that was fantastic. Go Portugal. And of course, everybody's still excited about, of course, Mexico and Germany. Mexico definitely taking a fantastic win as we continue to enjoy the FIFA World Cup 2018. Happy belated Father's Day, by the way, to all you daddies out there. And of course, happy birthday to our lovely Kalami Val, our co-host right here on The Breakfast Show. Remember that SMS number is 22162 if you want to interact with us and also send some fantastic wishes to those daddies out there, as well as our lovely co-host Val. Please tell us where you are watching from, and don't forget to start your text message with the words YM254. Also on social media, we are Y254 TV on Instagram, as well as on Facebook, and Y254 channel on Twitter. My name is Shiko Kaitani, and welcome to another edition of Hello Day. Now, every Monday, it's all about current affairs. And of course, with the World Organization calling all world leaders, to live up to the pledges that they made, agreeing to sustainable developmental goals, one of them being health for all, Kenya, of course, isn't being left behind, with President Kenyatta's Big Four agenda being universal health coverage. And so, in terms of health services, we're asking, what are we looking at and what services are actually available to the common mwananchi? That's what we're on today about. And so we're going to try to understand a little bit more about the health agenda. And helping me in studio today is Stephen Mutuku, who is here with us, a programs officer with HIV Investments. Karibu sana.
Thank you very much.
We're really glad to have you.
Sure, thank you.
Okay, so this is actually good news for all, not just Kenya, but of course on a global scale. But why don't we take a step back and actually define universal health coverage?
Thank you very much for the show. And basically, when we talk about universal health coverage, what we mean is that we want every person from whichever region and whichever community to be able to access all the spectrum of care. That is, we want everyone to be able to access the palliative care, preventive care, promotive care, rehabilitative care, with all equity, and whereas it is affordable. In this case, we are saying that from the definition that I've meant, it means that every person, irrespective of region, irrespective of location, must be able to access healthcare. Not just treatment. Not just waking up in the morning and going to the facility to get treatment, but you're able to access full treatment. I mean, the spectrum of care, whereby we want to understand the preventive mechanisms. We want to understand the rehabilitative mechanism of care. And we need the aspect of quality. Not just going to the facility, not just being told stop ABCD and to be well. But we want to understand, what is the quality which I need to undertake to achieve that kind of level of care. And finally, we need what we call the financial, the affordability aspect. We don't need to sell a goat. For us to access healthcare. But the government need to make it affordable. And those are the three tenets of universal health coverage, whereby we have the aspect of quality, aspect of equity, and aspect of financial responsibility. I mean, you can affordability.
Affordability. All right. And of course, the accessibility. Now, in your opinion, Stephen, what was so important about this agreement to be made on a global scale, and what does it really mean when we talk about universal health coverage for an individual?
Actually, what happened is when the 193 countries, they met in New York, I think 2015. And they are looking at the MDGs, the Millennium Development Goals, and they're transitioning them to the SDGs, that is the Sustainable Development Goals. One of the things they looked at was a safer and a healthier community. And what happened with that was there was a general agreement that by 2030, when we need to achieve the Sustainable Development Goals. We need a very healthier generation and a very healthy environment.
Yes.
And that is where they came up with a global agreement of the UHC 2030.
Yes.
The Universal Health Coverage 2030. Now, one of the key tenets of the Universal Health UHC 2030 is the aspect of leave no one behind.
Yes.
When we talk about leave no one behind, it means that the aspect of equity, whereby Shiku Kaitani has an insurance cover, which covers up to 3 million, 5 million.
Okay.
But we have a child in Turkana who needs to wake up in the morning and gets a snake bite.
Yeah.
This child must access healthcare by with all quality, which is expected. And so there was the aspect of system strengthening. That is actually what came up behind that. One of the key issues was about all the 198 countries, 103 UN countries must enable a political goodwill. So the first thing about this is political goodwill. And that is why the president said, one of my big four is UHC. I need everybody to access healthcare. Because you can imagine, if you may have the best roads in the country, you may have the best
but people are sick.
But with a sick generation, you need to wake up, take 3 tablets of or 2 tablets of paracetamol, so that you ease some pain, then you go and work. It means your productivity is from 8 to 1. You have too sick to work. And so the economic growth will be affected.
Okay. All right. So when we talk about UHC, the idea of domestic health financing comes in. Can you tell us a little bit about that and what the stats are currently, even in terms of this Big Four agenda being rolled out?
Yeah, actually, that is the way to go. And if I can talk from the HIV perspective, which I've looked at it from different spectrum, we realize that over 70% of what the money is used for HIV program in this country is donor funded. And actually, USA gives us 54%.
Wow.
Of what that money is. Meaning that we only spent around 30% from our country. That is what is allocated by the national government, by the county governments, and out of pocket, and even the private sector. But now, if we're going to achieve UHC, we need to change our frontier from donor funded to domestic resources.
Financing. Do we have that capacity though?
We have. And I think when the UHC talked about system strengthening, it means that we have the process. Of course, we have the infrastructure. But what we need is to realign our systems towards universal health coverage. I'll give you an example. We did an actuarial analysis and was asking ourselves, because today we have like 1.6 million Kenyans who are living positive. And from a human rights approach, these people should be accessing healthcare. But only at least 1 million, we have hit the 1 million mark on treatment. But if we put the 1.6 million Kenyans on treatment, and we all give them insurance, it means that we did an actual from 2017 to 2060. It means that we are, by 2017 alone, we estimated to spend 87 billion only for treatment, no prevention. And if you remember, last year we had issues with the strikes, the doctor strikes and all that. When we did the estimates, the country estimates on the new infections among the newborns, the prevalence moved from 8.3 to 11 point something. That means it's basically over 4,000 or 5,000 new infections among children. If we're going to keep these children alive up to the year 2060, that is around 40 years from today. By 2040, from our analysis, we'll be spending around 40 billion. Meaning that a disease like HIV is not going anywhere. We are here to spend on that kind of a disease. And then we have the the priority, the non-communicable diseases.
Yeah.
We have the cancers, the hypertensions, the diabetes, which are actually coming up.
Yes, chronic conditions now.
Very chronic conditions. And now we are talking about we need everybody to access. Now that tells us we need to actually think outside the box.
Okay.
From donor funding to what do we have within our country.
Yeah.
In addition to that, Kenya is moving from low-income country to low-medium income country.
Right.
Meaning that we are growing.
Yes.
And so we need to ask ourselves,
there's more purchasing power. Yeah.
Exactly.
Okay.
Who is going to provide for the health of our Kenyans?
Okay.
And from the domestic perspective, we have actually thought of different avenues.
Yeah.
And thinking outside the box, we're asking ourselves, what are the key drivers of health needs? And I want to look at it from the perspective of HIV, because I think that's where I've worked for a while. We did the SGR, which is a very key infrastructure for this country. But when you looked at Envoy, just for instance, the preference is Envoy, the HIV prevalence, the infections in Envoy grew from 3% to 6%.
Okay.
That gives us one quick answer. Development projects are a key driver to new infections and other diseases.
This is interesting. I didn't even look at it that way, but okay.
Then, in addition to that, assume we are doing a road.
Yeah.
And we are doing the road in the village because we are talking about devolution, decentralization, equitable growth. What happens when, as a child in the village, sees this caterpillar and the tractor just leveling the road? They come stand there, look at the road and say, oh, this is how it does it. What will happen next? That dust gets to your chest. The next day the mother is taking the child to the hospital.
Right.
But when you are doing when you're giving out that project, NEMA makes it sure that we have an environmental and the impact mitigation. I mean, environmental and health and impact allocation for that. But if you move to many corners of this country and you see a road being done, they say the contractor or other aspect, and down there is HIV queues.
Yes.
But we had an allocation for prevention. An allocation for that.
And I actually do want to engage you a little bit about that. What exactly is being done then in terms of the cases of preventative measures as opposed to treatment? Do you think that's what we need to even be focusing a little bit more on then?
Exactly, because one thing is prevention is very cheap.
Yeah.
But very expensive, because on prevention you are looking at the whole spectrum. I mean the whole population. The 47 million Kenyans. But if you took a prevention, it's only the few who got sick. So what the point I was driving in was that in terms of domestic resource mobilization, we need to relook at the development projects. How much can we get from the environmental and the impact mitigation?
Okay.
And that connects to the other big four. We have the housing.
Yeah.
I know in the budget, although that's a question which may come later, is about allocations to the housing.
Yeah.
And allocation to the food security and manufacturing.
Yeah.
I mean, the budget put in some monies for that.
Yeah.
But how much will be the interaction? Or how much migration will be meant with housing? Okay. There'll be a lot of works which will be ongoing.
Yeah.
There'll be a lot of maybe injuries. And so we need, as we're doing the budgeting for such projects, we need to put in a share of the environmental and the impact mitigation. Okay. And all that money now can be used for health.
For health, okay. So that is your idea of how we can fund ourselves domestically.
That is one of the ideas.
Okay, but let's.
But two, we are talking about the different mechanisms.
Yeah.
When the minister, the CS, was reading the budget, he actually increased the tax from the M-Pesa, the money is the M-Pesa
transactions, yeah,
from 10% to 12%.
Yes.
Meaning, and decide the increase will be used for universal healthcare. I actually googled when we was doing the speech.
Yeah.
And I realized that I think 2016 or 2017 we transacted 1.7 trillion.
Wow.
So if we do the same this year and we only have the 2% going to UHC, that amounts to 34 billion.
So we've got the solutions.
It means that
we've got models. We've got models that can work.
We got the models.
Yeah. Okay. Yeah. So from your experience, or from of course, you being part of the entire UHC plan, can I put it that way? You definitely do have access to this information. What has been done so far, even in terms of driving, publicizing this agenda? You will speak to that local mwananchi who will tell you they've never heard of something like this called UHC. What is this? And what has been done so far in terms of our calendar for 2018? By the way, coming from the government, not necessarily, of course, all these other sectors that are putting in.
Okay, one of the key drivers, the driver to UHC, which is actually being mooted, is use of the NHIF. Yeah. And the country, the push is that by 2022, all Kenyans should be okay, of course, because you can't be forced into it. Should be under the NHIF. Yes. And actually, as per this year, I know NHIF has moved to banks, have used to chairmans.
Yes, they are quite
have
proactive,
moved to the religious community, so that we have more pooling. Because when you talk about social insurance, it's about your 500, my 500, somebody's 500. When you pull in that monies,
the crowdfunding,
yes, we'll be able to have more funding for healthcare. Okay. But what is more important is to reform the financial operations of NHIF. Okay. To be aligned to UHC. Okay. And I think that was something which came up very clearly in the budget.
Okay. And allow me to just throw in this a little bit before we continue talking about UHC generally. There's been a lot of focus. I don't know whether it's because the First Lady, of course, has been the face of this. Of course, we've got Beyond Zero, and there's Linda Mama, and there's a lot of focus on maternal health care. In your opinion, do you feel that, by the way, they're not doing enough to diversify this coverage? Because when we talk about TB, we talk about HIV. This is huge, and there's a very large number of individuals, or a huge population dealing with, like we talked about, HIV, TB, you name it. What's your take on that?
Maternal health care is very important. Yeah. And a mother does a lot. And as I mentioned, like last year, because of the strikes, HIV ward in Kenya was it. Because if you're talking about a mother who was not taken care of up to delivery, ended up delivering HIV positive child. From the costing analysis that we've undertaken, the cost of managing an HIV patient in a year, if we're going to do quality, within the tenets of UHC, quality, affordability, equity, that person is supposed to spend between 42,000 and 47,000. Right, yeah. Now, if we talk about, just say 1,000 new infections among children, it means that the country should put aside 42 million every year for that particular population for 1 year. Yeah. Something that would have prevented. Leave alone to that, it means that the mother maybe was living positive. It means now we have 2 patients. Another mother is weak. So when you talk about maternal health care, it's actually the start of life. Okay. And I actually congratulate the First Lady for putting her effort in up, because it actually flows to other diseases like HIV, TB, and the rest.
Okay. All right. So we've talked a little bit about the calendar. We've talked a little bit about budgets. Maybe you can still expound on that. But Stephen, of course, there has been the ongoing debate from those in the medical field that there's too much focus as well being put on UHC, on the coverage, and not enough emphasis being put on the practitioners themselves, so that even if you're giving people coverage, what are you doing so that when they actually go to access these services, they are qualified, satisfied individuals working on the other end? Your thoughts on that? Because of course the doctors strike, the nurses strike, that has just been, you know, such a huge blow to the country.
Yeah, I think when I started mentioning about the UHC, the first bit is about system strengthening. And systems, if they are not strengthened, basically will not achieve UHC. And I think that is where your point comes in. For us to achieve UHC and have all the stakeholders included and satisfied, one, we need to relook at our systems. And that's why I've said we need to want to strengthen the devolved health systems, because remember, health is devolved, and the counties should take care of their health systems. So when we talk about system strengthening, we need to start at the counties. One, are the facilities operational? Do we have the drugs? Do we have the human resource for health? Are we doing the right procurement process? If I buy paracetamol in one hospital at 30 shillings and I buy another one at 50 shillings, why the disparity? Now, those are some of the issues that need to be relooked again. And then the next thing is, I get NHIF. Am I able to use NHIF both for inpatient and outpatient? These are not some of the systems that needs to be strengthened. And as I mentioned, we're not just talking about going to the facility, but even the preventive. When I was growing up, we had a very strong public health division in this country, whereby you could not even go to the butcher and buy meat if it is not stamped.
That's true.
But today,
look at what we're dealing with.
We need to look back at that kind of a system and ask ourselves, are we preventing the health of our Kenyans? And I was saying, for us to achieve the UHC, all the systems in the health sector must be achieved. How do we control TB? Are we going to manage cancer? What kind of diet should we take? Those are some of the things we need
and we keep overlooking. Everybody is looking at just the treatment, but we're not thinking about the prevention,
which is very expensive. So I think the cry is genuine, because if we all run to the facilities, it means that we're overwhelming the doctors and the nurses, and we not get quality. And some of us will be forced to run to the private health facilities. Exactly. But we want affordability within the UHC.
We're going to ask, of course, this question because now we want to try and zero into an individual. How can one go about accessing health coverage? And from you know, your research or your opinion, maybe you can tell us which areas of focus the government has decided in terms of universal health coverage to actually look at as they begin, you know, their rollout plan.
Let me start by saying that universal health coverage achievement is a process. And we're actually talking about up to 5 years from today. And to start on with the process, what the government has done, have put in different tiers of responsibility. Like we have like an inter-ministerial committee that reports to the president on how are we doing on UHC. Whereby, and in that committee you have the CS Health, the PS, and the heads of the different organs in the ministry. Then down at the Minister of Health, we've set up, there's a committee which actually looks at the different areas of UHC. And one of the key committees is, we have a financing committee, an health financing committee, that will look at how is this whole issue about UHC, how will it be financed? Because it's really expensive.
Yeah.
And it can even cost a lot of money for this country. So the question is, how are we going to finance this? And that's why the question of domestic resources came in. Then we have the second, another committee on service delivery.
Okay.
In terms of service delivery, we want to understand what is the minimum package that you can get in the different tiers of facilities. We have the dispensaries.
Okay.
What is the minimum benefit benefit package for health that you can get at the dispensary? What you can get at the clinic?
Yeah.
I mean, at the health center, up to the referral hospital.
Yes.
Or should somebody just get an headache, move from the dispensary to Kenyatta? We want to understand at the different levels.
Yeah.
What can I benefit?
Yes, exactly. That's
And what can then NHIF cover?
Okay.
Then we have another committee on communication. In terms of communication is whereby advocacy comes in.
Yes.
How shall we communicate UHC
yes,
to
the public,
to the person at the village?
Okay. Okay.
How will you talk to the guy at the community? Tell them today you can access healthcare at the facility instead of spending monies which would have used to buy a book for your child.
Okay.
Because if I'm going to use monies from my pocket to buy to access healthcare at the expense of my child's education, it has a ripple effect in future.
It does. It does. Okay.
Then we have the monetary and evaluation committee, which will be relooking at how are we moving in the implementation of the UHC.
Okay.
But to zero down on now the individual, after the devolution, you remember, I think last year, is it last year but one?
Yes.
The government came up with the issue of leasing of equipments.
Yes.
So cancer issues have actually been relooked at individual level. And I believe an example is Kivuta, Kivwana and Makueni, how they're accessing UHC. And also, just to zero down, the country now is moving to implement or to pilot UHC in 4 counties.
Okay.
I know Machakos, Kisumu, no, Nairobi, Kisumu, I think Nyeri and Machakos.
Okay.
So we'll be down. Yeah.
Okay. So what is your final word, because we have to say goodbye and we need to wrap up the conversation. What is your final message to those who are watching concerning youth health, universal health coverage, and what can they look out for?
One, universal health coverage is we want to reduce a lot of out-of-pocket utilization for health. And one of the key issues we need to look at is how is NHIF going to support us?
Okay.
So one word for you guys is we need to enroll under NHIF because very soon we'll be able to have a very vibrant NHIF system in this country.
Yes.
And 2, we need to relook at our preventive. Let's prevent our health before moving to the facility, because it is very expensive to get healthcare from to get money to spend on healthcare at the facility level. But if you prevent, it is basically cheap.
Okay.
Yeah.
Okay. All right. Well, thank you so much. I think that gives us a great head start in terms of understanding what universal health coverage really is. And I know we'll continue to have subsequent discussions, because like you said, it's quite a process and there's so much to cover.
Sure.
But we hope that you'll be back in studio again as we continue to at least dissect the discussion of universal health coverage.
We'll let Kenyans understand this UHC agenda and keep them safe.
Okay, fine. Well, thank you so much. We want to say a big thank you to Stephen Mutuku, who's in studio with us. He is actually a program coordinator at HIV Investment, and talking to us about universal health coverage and understanding what the health agenda really is, which is part of President Kenyatta's Big 4 agenda. Like we said, it's quite a process, but we also want to encourage you to look it up, read more, understand why you need to actually register under NHIF and why it's going to benefit you in the long term. On behalf of everyone right here, of course, on our breakfast crew, we do want to say thank you so much for keeping it Y254. We'll see you tomorrow from 9 a.m. till 10 a.m. on Hello Day with me, Shiko Kaitani. Have a good day.
Thank you.